Welcome back, my friends. Today on Veterinary, we're talking about various calcium derangements in canine and feline patients with kidney injury. Before we start, I just wanted to let you know that if you want to watch a free 35-minute workshop on comprehensive blood gas analysis and download a free copy of the acid-base analysis worksheet that I use in my personal clinical practice, click on the link below located in the description section. All right, let's dive in and chat about calcium metabolism first. Calcium homeostasis is a complex process that involves 5 key components: serum calcium, serum phosphate, calcitriol, also known as active vitamin D or 1,25-dihydroxyvitamin D3, parathyroid hormone, also known as PTH, and finally, fibroblast growth factor 23 or FGF23, which is a hormone that plays a pivotal role in phosphorus and calcium regulation. All of these components regulate calcium metabolism in the 3 core body systems: gastrointestinal, renal, and musculoskeletal. It is a well-known fact that calcium has to be consumed from the diet because animals and people can't make this mineral. Therefore, the amount of calcium stored in the body largely depends on dietary intake, intestinal absorption, bone remodeling, and renal excretion. If an animal doesn't eat enough calcium, the body will move calcium from bones to blood to maintain serum calcium levels at a constant level. Today, we will focus on how kidney disease may interfere with this complex calcium metabolism. What's interesting is that both acute and chronic kidney disease may lead to hypo, hyper, or normocalcemia. In a cohort of 238 cats with hypercalcemia or elevated calcium in the blood from a referral hospital population, 13% of these cats had acute kidney injury or AKI, and 8.4% of these cats were diagnosed with chronic kidney disease or CKD. On the other hand, Cody et al. Described 450 cats with hypocalcemia or decreased blood calcium level. In this paper, kidney injury accounted for 21.6% of all cases of feline hypocalcemia, of which 62.9% were diagnosed with AKI and 37% were diagnosed as CKD. Urethral obstruction accounted for about 15% of all cases. So why would some animals with kidney disease develop low blood calcium concentration while others develop high calcium levels? Answer this question. Let's first briefly talk about calcium homeostasis in healthy animals. In health, a small decrease in serum calcium causes the parathyroid gland to secrete more PTH hormone. PTH, in turn, will have 3 important effects on calcium homeostasis. First, in the kidney, PTH will increase tubular calcium reabsorption. Second, it will also increase calcitriol secretion. As a result, calcitriol will lead to calcium reabsorption in the gut and will decrease PTH secretion in the parathyroid gland, which will create a negative feedback loop. Lastly, in bone, PTH will increase net bone resorption. What about AKI situation? AKI causes an abrupt decrease in glomerular filtration rate, or GFR, leading to accumulation of phosphorus in the blood, also known as hyperphosphatemia. An increase in serum phosphate stimulates FGF23 secretion from bone, which acts in proximal tubular cells of the kidney to decrease phosphate reabsorption, resulting in net excretion of phosphate from the body. On top of that, FGF23 reduces renal secretion of calcitriol, which decreases intestinal phosphate and calcium absorption. To a lesser extent, markedly increased serum phosphate concentration leads to mass law interactions with calcium that may result in decreased ionized calcium as well. From experimental research, we know that to decrease ionized calcium concentration by only 0.02 millimoles per liter, serum phosphate concentration must increase by 3.7 milligrams per deciliter. These complex interactions and pathophysiology behind the development of hypocalcemia secondary to AKI can be summarized in these two simple statements. First, AKI causes hyperphosphatemia that promotes reduced calcitriol production by FGF23 in the kidneys, leading to decreased serum calcium. Second, AKI-induced hyperphosphatemia causes direct reduction in ionized calcium by physicochemical reaction. But why would some other patients present with hypercalcemia as opposed to hypocalcemia associated with AKI or CKD? As renal function decreases in patients with AKI and CKD, increased phosphate retention results in a rise in serum phosphate and FGF23 levels. Meanwhile, a reduction in calcium absorption caused by decreased calcitriol secretion leads to a fall in serum calcium and a rise in PTH. Chronic elevations of PTH, in other words, secondary and then tertiary hyperparathyroidism, result in increased tubular calcium reabsorption in the kidney and bone that will eventually lead to normalization of calcium levels followed by hypercalcemia. In secondary hyperparathyroidism, the serum calcium is normal and the PTH level is elevated, while tertiary hyperparathyroidism is characterized by excessive secretion of PTH after long-standing secondary hyperparathyroidism in which hypercalcemia has ensued. Are there any other causes of hypocalcemia in animals with AKI? Well, yes. Another important consideration when dealing with severe ionized hypocalcemia in a feline or canine patient presenting with AKI is a possibility of ethylene glycol toxicity. It is a well-known fact that metabolites of ethylene glycol, or EG, can chelate calcium and become deposited in soft tissues, including kidneys, resulting in severe hypocalcemia. Hypocalcemia often develops later when renal function is severely reduced from acute renal failure and when hyperphosphatemia is severe. Whoa, that's a ton of pathophysiology compressed in one short video lesson. I hope I didn't overwhelm you. Although it might be cool to know all this information and impress your colleagues and friends, you may not need to know all of that in your clinical emergency practice. However, I would take away the following bullet points from this conversation. First, cats and dogs with AKI may have low, normal, or high calcium levels depending on the stage of the disease and other comorbidities. Second, hyperphosphatemia is the main pathophysiologic mechanism that is driving complex hormonal changes resulting in calcium derangements in this population of patients. Third, ethylene glycol toxicity should be highly suspected in outdoor animals presenting with severe AKI and ionized hypocalcemia. And finally, marked ionized hypocalcemia such as less than 0.7, 0.8 millimoles per liter may lead to severe clinical signs including tremors, seizures, hyperthermia, facial rubbing, hypersensitivities to stimuli, arterial hypotension, and ECG abnormalities such as prolonged QT interval. Therefore, it should be corrected as soon as possible. All right, this should be it for today, and I'll see you next time.